Hello, this is Allison Kurian, and I'm pleased to be able to speak today about our work on the OncoShare project. The background and goals of this work stem from the fact that cancer data sources are fragmented. Cancer registries have demographic and survival data, but very limited data on diagnostic testing and treatment. By contrast, electronic medical records are rich in clinical detail, but often have unstructured text that is difficult to mine. Furthermore, send-out laboratory test results are generally not well integrated into EMR data. And most data sources do not span healthcare settings. In the OncoShare project, we aim to integrate data sources across healthcare systems with the goals of enabling quality assessment and to inform interventions to improve care. In this work, we used two contributing healthcare systems that serve the same area in the San Francisco Bay Area. Stanford Hospital and Clinics, associated with Stanford University, is academic, tertiary care, and research centered, and has several sites as shown by the red arrows on the map. The partnering institution, Palo Alto Medical Foundation, which is an affiliate of the larger Sutter Healthcare System in Northern California, is a community-based healthcare setting known for patient-centeredness and with several sites, again, across the same catchment area. In terms of the design, we used patient-level data drawn from the statewide California Cancer Registry, a component of the U.S. Surveillance Epidemiology and Results Program Cancer Registry, and electronic medical records from these two healthcare systems, while also integrating outside genomic laboratory results. You can see here in this figure that we have basically sources of data, including cancer registries and electronic medical records. We then have various procedures for anonymizing the data, which are then aggregated and shared into this OncoShare data set. In terms of progress, as of July 2020, the dataset contains more than 28,000 breast cancer patients diagnosed and treated over the last 2 decades, with more than 40 publications and presentations on the data to date, which are summarized on the OncoShare website shown here below. And I'll give some examples now of the kind of work we can do with this data set. One line of investigation has been to look at variation in care and ways that it may not be warranted. So one example is that in this data set where we looked across healthcare settings, about 15 to 20% of patients actually seek care for their breast cancer at both the university or academic and community institution in the same area. That might be because they are, as we might say, doctor shopping for a particular aspect of care, or that they might be receiving surgery at one site and radiation at another. But the upshot is that when one looks at these patients, there is absolutely no difference in cancer prognostic factors in any of the ones we know about between these patients who see both institutions versus the others. And in fact, those patients seen at both institutions receive substantially more imaging with modalities such as MRI and PET, more invasive surgery with bilateral mastectomy, chemotherapy, and radiotherapy, as shown by the significant p-value. But there is no survival difference between these populations on multivariable analysis. And you can see one illustration in the figure. Patients who are seen either at the university site or the community site receive about the same amount of diagnostic breast MRI at the time of cancer diagnosis, whereas those seen at both centers receive about double the amount. And that's just one example. So this kind of data allows us to zero in on hotspots of what appear to be unwarranted variation in care and may inform targeted interventions. Another example is discovering new biomarkers associated with immune function and survival. This is an example from a cohort of triple-negative breast cancer, an aggressive breast cancer type, of which we studied about 1,500 patients in OncoShare, who unfortunately, a quarter of whom had died within 5 years of their cancer diagnosis due to its aggressiveness. And here we investigated a routinely collected component of complete blood count, the peripheral absolute lymphocyte count, which some others had found to be prognostic in other cancer types and is a measure of immune function. And as shown here in the figure, we found that both for overall survival and breast cancer specific survival, people had substantially worse survival on multivariable analysis if they ever had this low absolute lymphocyte count. So again, an example of biomarker discovery from these kinds of data that can inform future work, which we're embarking on now. A final example is using this kind of a data set to develop models for identifying important clinical events. And one here that we looked at was distant metastatic recurrence, a clinically important endpoint that is not tracked by cancer registries. And so to do this in the OncoShare project, we manually annotated about 900 randomly selected patient records for whether they had a metastatic recurrence or not and the date. We used natural language processing to develop rule-based and neural network models. And as shown, we had a training set and a test set vectorizing notes into a deep learning model and having an output, which was a probability of recurrence, as you see here in our recent publication. This had significant sensitivity at 83%, specificity at 73%, and is quite adaptable for cancer types other than breast. In terms of future plans, we're interested in integrating novel data sources, including tumor sequencing data, imaging data, and patient-reported data from EMRs. We're also very interested in scaling this work and are partnering actively with other healthcare systems to validate and improve these approaches, including collaborations with Emory and MIT and Vanderbilt in the United States, and a collaboration with the Ku Foundation Sun Yat-sen Cancer Center in Taiwan. We've also done some consulting with the Surveillance Epidemiology and End Results Program to share approaches that may inform some of the SEER registry's work in data integration. I'll stop now and acknowledge the many collaborators in this work from Stanford University, Palo Alto Medical Foundation, other institutions, and our funders. Thank you very much.